Hello, hello, it's Gigi, your favorite nurse practitioner here. I promised you guys I would do a video about working bedside nursing in the transition with being an acute care nurse practitioner and working bedside ICU. It's not going to be too long, but I'll give you a few pointers on where to start. Number one, you're going to go work as an agency nurse. You have to have a mindset to be an agency nurse. Number one, again, when you get there, you know that you're probably not going to know where everything is. It's okay. It's your first night. You get a tour of the unit. If you're lucky, you get 2 nights of training. If not, you get one. But you have to have a mindset of, listen, I'm going to walk into the situation. This is not my norm. I'm not going to know where everything is. It's okay. Your first week is going to be the roughest one. After that, you get to kind of familiarize with where your stuff are. And it's not going to be that hard. A good thing to remember, be on time. You're going to be at these people's job. You can't be showing up 5 minutes late, 10 minutes late, 15 minutes late. No, you be on time. If your shift starts at 7, at least, if that's your first time going, I would say at least 30 minutes so you know where to park. You might say like, okay, I'm going to know where to park, and you get there, you can't find any parking. This is your first night and you're going to be late. That's not a good look for you. So if that's your first time going there, you don't know where parking is, get there at least 30 minutes early. If you kind of know the place, you know where you're going to park, you know the situation, at least 15 minutes before your shift start, you should be inside the lounge or wherever they're going to do huddle or wherever you need to be. It's not 15 minutes to leave in your car. 15 minutes you should be inside these people's facilities and ready to work. This is what you're there for. Okay? When you go work and you were a nurse practitioner and now you're working as bedside, the goal is the same. Whether you're a nurse practitioner, whether you're a bedside nurse, it's keeping your patients safe, right? For the shift, you're going to make sure your patients are safe, whether you work as an NP, whether you work as a bedside RN. Number 3, you have to be a team player. You're not going to go there with the notion in your head, oh, I'm an agency, I'm going to be separated. No, you're part of the team. If the next nurse needs some help, guess what? As a matter of fact, I make it my duty to go around and let people know, I'm Gigi. If you need any help, please let me know. Okay? Do your work. You're not there to socialize. I'm not saying for you to be antisocial, but you can't be there and this people's job and then you taking over the place. No. So you be there, be a team player, you do your work, you socialize, but make sure your work is done. All right? Now, for you to work as a bedside nurse from a nurse practitioner standpoint, you still do your assessment. So you get to work. You go see your patient after you get report. I have a report sheet, which I don't have one with me, but I'll show it to you next time. I carry my own report sheet that has the complaint of history, neuro, respiratory, cardiac, renal, GIGU, lines, antibiotics, and labs. So I have my own pre-made sheet that I carried with me. So when I'm getting report, it's easier for me because I'm used to it. Okay. So after you get report, you go, I normally take a look at my patient with the outgoing RN to make sure, I take a look at my patient. All right. All my patients for that matter. I normally have 1 to 2. Okay. So you go in the room after the nurse leaves. Now you're going to do your assessment. You do your regular head to toe assessment as a nurse would, whether you're a nurse practitioner, whether you're a nurse, you still have to look at your patient head to toe. When I was doing nurse practitioner, I still carried my, pen light with me. I still look at people's pupils. I still uncover patient to look at the belly. Not always, but a lot of time listen to long sounds. So it's the same thing you do as an NP. You're going to do it as a bedside RN. So you do your full head to toe assessment. You start with your neuro. You look at your patient's pupil. If they are ventilated, you check your vent settings. Make sure whatever they told you in report is what it is. You look at your volume, more like a nurse practitioner thing, but I still keep it as an RN. I look at my respiratory rate, my tidal volume, my IE ratios, all those stuff, my minute ventilation, I still write those down on my paper in case there's a change later, respiratory rate, so I know what the baseline was from when I started and where I'm at now. Also, you look at your ET tube. They told you it's a number 8 at 23 at the lip. You verify that. If now you see it's a number 8 at 20 at the lip, so you know that the tube got pulled back and your patient's having respiratory distress. So those things are the same. You listen to lung sound, you listen to your heart sound, you do palpation, you verify your NG2, you do your NG2 verification, all part of nursing stuff. You check your Foley, urine output, make sure that there's a stat lock on the Foley to make sure it's not pulling. Those are part of your nursing stuff that you do. When you look at your NG tube, you're going to make sure that it's secure. Normally wrap around the ET tube, make sure it's secure or it's not pulling out. You check your patient's pulses because those are things you're going to have to document, part of your nursing assessment. Okay, after I finish doing my nursing assessment, I check all my tubings. Some hospital are 48 hours. I make sure my tubings are not expired. If they are, I put that on my list, how many tubings I have to change, what I need to bring in. I know for the morning, I'm going to need to have a piston at the bedside for the new shift for NG2 verification. I'm going to need a new mouth care kit at the bedside so they don't have ventilator-acquired pneumonia. I'm going to need, I did a little note, if my central line needs to be changed, I need a new kit. So pretty much my piston, my mouth care kit, my suction canister. It's nasty when you leave all that gunk there for the next shift. So make sure you change that as well. All right. So I make a list of stuff that I'm going to need and I bring that with me next time I go into the room. So I set up my room so everything can be in order. Okay. After that, I normally I look at all my labs, right? I look to make sure there's nothing pending that is due to be done right now, because sometimes you might have a 2000 troponin or 2000 CMP recheck. So you make sure nothing is due now. Then I do a little list as far as my meds. My 20, 21, 2200 meds, I classify them at once and I give those at 2100, unless it's something that is necessary to be given now. Let's say it's a Colis or a Protonics, one is at 2100, one is at 2200. I'm going to do 2100. I give both. Okay, so I separate my 20, 21, 22, my midnights and 1 o'clock at the same time, and my 4, 5, 6 o'clock at the same time. So at 5 o'clock, I would go ahead and give those meds. Normally, I have a good night, and normally by 7:30, I'm done working. Okay, so you do that. After you pass your meds, you do your physical assessment. You can chart it. Depend if you have time before you pass meds. If you do on a 2100, you're done with your full assessment. Don't start documenting until you assess your patient. So you sit there, you assess your patient, and then you chart, then you give meds. Okay, you kind of space out your night, how your night's gonna go. You know this patient now, because I work with COVID. You can't flip and flop these people like we normally do in an ICU, because they will decompensate on you and they will die. Okay, so we can't be like every 2 hours we fluffing and flipping these people like that. But in a regular ICU, you know, every 2 hours you are turning and flipping your patient. Those COVID patients are very critical, so we're not flipping and flopping like that. But if you can, you do it. If they maintain their oxygenation, you have to do risk versus benefit. As an NP, I find myself, if my patient is desaturating, if they were on a PEEP of, let's say, 5, I tend to try to go up on a PEEP of 10, I'm getting into the, I'm thinking like I'm an NP, but no, I had to pull myself back. Gigi, you're the bedside nurse now. You need to let your critical care nurse practitioner or your intensivist know that this patient is deciding. You suction, you increase FiO2 or whatnot. You let respiratory know and ask them what would the plan be. Normally, I find myself want to increase the PEEP or increase the FiO2 or, you know, do something with the tidal volume or whatnot. You're not a nurse practitioner. You're a bedside nurse. So you need to know your scope and stay within your scope. Is it going to be hard? Maybe the first week, a little bit hard, because you know what? You don't know where things are. You're trying to get to know the charting. By now, I think I know all Broward County charting, because I've worked at pretty much every single hospital in Broward County. So I know the charting now. But one of my hospital, when I got there, they only gave me one night of training with the charting. Okay, the second night, I didn't act like, oh my God, I'm not going to be able to do this. You go in with the mindset that you can do this. I'm doing it now for a couple weeks and everything is great. Whatever you don't know, ask. Ask the people who are full-time. Ask the people who are here. Again, you need to be nice to the people you're working with. You cannot come into this people facility. You're full of attitude. You're full of like, oh my God, I have 2 patients. Oh my God, I have 2 patients. Honey, you're an agency nurse. You already know this is a setup. You are going to probably get the worst patient. You are probably going to be floating. You are probably going to be getting the admission. You are probably going to be the one with the open bed. Honey, you here for one purpose. At least I'm there for one purpose. As long as my patients are safe, I know exactly what I'm there for. So I don't care if you give me 3 patients. I don't care if you put me on top of the roof with a Pyxis machine. As long as I'm in a safe environment, I can take care of my patient. There's no complaint from Gigi. Every Friday, I'm getting paid. So when you switching your mind from being a nurse practitioner to a bedside nursing, just the stuff I just said above, do your assessment. Don't change the vent because that's what we normally would do. All right. Call your intensivist, ask him, give him, listen, this is what that was. You giving them information. If they're giving you new orders, either put it in or they're going to put it in. Okay, the first one is going to be a little rough, maybe the first couple of days, but after you go back and forth, you start getting familiarized with the people you work with the environment, with the charting, and it gets easier. At the end of the day, you're there for one reason. At least I'm there for one reason. So you make sure that your work is done. If your charge nurse for that unit comes to you, tells you, oh, you didn't charge this that way. In your head, you know you did it, but that's not how they want their facility to do it. You do it the way they want you to do it because you at this people's place. This is not your personal work or whatnot. You are a guest at this people's facility. So if they told you, this is how I want this charting done, or that's not how I used to do it. No, honey, you do it the way they're telling you to do it. Okay? All right. If you guys have any particular questions, please feel free to ask me in the inbox or comment under there. Don't forget to follow me. Don't forget to like as well. If there's something you don't like, also you need to let me know, because if I don't know, I can't change it. All right. So please put all your questions below regarding the transition in from nurse practitioner to bedside RN, all in critical care. All right. This was Gigi, your #1 nurse practitioner, business owner, hustler 24/7. I'm doing me all day, every day, baby. Don't listen to what people got to say about you. You do you. As long as you're okay and you're not hurting anybody, you keep doing you. I love you all. Mwah. Bye.